Now we'll discuss about the anatomy of the median nerve. Median nerve is also known as laborer's nerve. So in this diagram, you can see here is position of humerus. Here is radius. This bone is radius. Here is this is ulna. Here is interosseous membrane. This is interosseous membrane. This is interosseous membrane. Connect the interosseous border of radius and ulna. This is interosseous membrane. And here is position of flexor retinaculum. This is flexor retinaculum. This is flexor retinaculum. This is scapula. In this diagram, here is position of ventral rami of C5, ventral rami of C6, ventral rami of C7, C8 and T1. The ventral rami of C5 and C6 join to form upper trunk. This is upper trunk. This is middle trunk. C7 form middle trunk. This C8 and T1 join to form lower trunk. So this is upper, this is middle, and this is lower trunk. And these three trunks divides, give dorsal division. This is the dorsal division of all three joined to form posterior card. This is posterior card. This is posterior card. And ventral division of upper and middle trunk form lateral card. So this is lateral card, this is posterior card, and this ventral division of lower trunk form the medial card. So this is lateral card, medial card, and this is posterior card. Here is position of axillary artery. This is position of axillary artery, third part of axillary artery. This axillary artery continue as a brachial artery. This is axillary artery. Here is lower border of teres major. From lower border of teres major, it continues as brachial artery. This is brachial artery. Now, another structure which is related to this, that is, here is supratrochlear spur. This is supratrochlear spur. Supra spur. This is supratrochlear spur, and this is medial epicondyle of the humerus from here to here. Sometimes a ligament is present known as Struther's ligament. This is Struther's ligament. This ligament is rarely present. This ligament has a morphological importance. It is third head of coracobrachialis muscle. It is rarely present, and if present, it may create some problem. We'll discuss later. So here is supratrochlear spur. This is supratrochlear spur. From supratrochlear spur to medial epicondyle of the humerus, there is Struther's ligament. It is rarely present. Then come to, here is position of brachioradialis. This is imaginary line between two epicondyle, medial and lateral epicondyle of the humerus. And here is, this is pronator teres. This is brachioradialis, this is pronator teres. And this fossa is known as cubital fossa. Here is cubital fossa. This pronator teres has two heads. One head is arises from the medial epicondyle of the humerus, and the head is from the ulna. So there is two heads. Between these two heads there is a gap. Another thing, here is position of one muscle. This is a small part of the muscle in the diagram. Whole muscle is not drawn here. So this muscle is a radial head. Radial head of flexor digitorum superficialis. This is a radial head of the flexor digitorum superficialis. Another thing here is this is lateral half of flexor digitorum profundus. This is lateral half of flexor digitorum profundus. And the muscle is flexor pollicis longus. This is flexor pollicis longus. And another muscle is present here. This muscle is pronator quadratus. This muscle is pronator quadratus. Pronator quadratus. Another thing, here some muscle takes origin from here. This is common flexor origin. The muscle takes origin from here are flexor carpi radialis, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis. Flexor digitorum superficialis. So these muscles takes origin from here. Now, another thing is, here is three muscles of the thenar eminence. These muscles are abductor pollicis brevis, superficial head of flexor pollicis brevis, and another muscle is opponens pollicis. So these are three muscles of the thenar eminence. Actually, there are four muscles present in thenar eminence. These are abductor pollicis brevis, superficial head of the flexor pollicis brevis, and there is another deep head of the flexor pollicis brevis, opponens pollicis, and another muscle is adductor pollicis. So these are four muscles present in thenar eminence. But here we make only three muscle diagram in this diagram. Another muscle, that is lumbricals, first and second lumbricals. These are first and second lumbricals. Lumbricals, first and second. First and second lumbricals. Now we will discuss about the medial nerve. Before starting the medial nerve, I will make another diagram. If you cut a section at this level, here you will find this is trapezium, here is trapezoid, here is capitate, and here is hamate. This is carpal tunnel. This is carpal tunnel. Here is flexor retinaculum. This is flexor retinaculum. And deep to this, here is ulnar bursa. Here are four tendons of flexor digitorum superficialis and four tendons of flexor digitorum profundus. Here is flexor tendon of flexor carpi radialis. This is flexor carpi radialis. Here is tendon of flexor pollicis longus. This is tendon of flexor pollicis longus. It is passes through the sheath. That is, this is ulnar bursa. Here is radial bursa. This is radial bursa. So here is position of thenar muscle. Here is hypothenar muscle. This is thenar muscle. This is hypothenar muscle. Now we will discuss about the course and relation of the medial nerve. So in this diagram, This is lateral card. This lateral card gives three branches: lateral pectoral, musculocutaneous, and this is lateral root of the median nerve. This is lateral root of the median nerve. Medial card gives five branches: medial pectoral, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and this is ulnar nerve, and this is medial root of the median nerve. So this is median nerve. This is median nerve. In axilla, its position is anterolateral to third part of the axillary artery. It has two roots, lateral root and medial root. Root value of lateral root is C5, C6, C7. Root of medial root is C8 and T1. So, this nerve initially lies laterally to the axillary artery, then it goes into arm. Here its position is also lateral. Now, in the middle of the arm, it crosses the axillary, this brachial artery from lateral to medial side, like this. Now its position is medial. If Stutzer's ligament present, it passes deep to Stutzer's ligament. In cubital fossa, it gives branches to this elbow joint, and it gives branches to this muscle flexor carpi radialis. It gives branches to palmaris longus. It gives branches to flexor digitorum superficialis. After giving branches to these muscles, it passes between two heads of the flexor, two heads of the protractoris. This head is humeral head, this is ulnar head. It passes between two heads here. After passing between two heads, it gives a branch that is known as anterior interosseous nerve. This is anterior interosseous nerve, passes anterior to interosseous membrane. This anterior interosseous nerve gives branch to this muscle. This is lateral half of flexor digitorum profundus. It gives branch to flexor pollicis longus. Flexor pollicis longus. It gives branch to pronator quadratus. Pronator quadratus. So this is anterior interosseous nerve. It gives supply to 2.5 muscles. One muscle is pronator quadratus, and there is flexor pollicis longus, and there is lateral half of flexor digitorum profundus. This is purely motor branch. It has no sensory fibers. Now, after giving these branches, this nerve turns laterally. On lateral side, it gives branch to this muscle. This muscle is radial head of flexor digitorum superficialis. This is flexor digitorum superficialis. It gives branch to this, and then it runs downward up to flexor retinaculum. About 2.5 centimeter proximal to, about 5 centimeter proximal to this, it gives a branch that is known as palmar cutaneous branch. This is palmar cutaneous branch. It gives supply to skin over the thenar eminence and lateral to two-thirds of the concavity of the palm. So this area is supplied by this palmar cutaneous branch. This passes superficial to flexor retinaculum. This is flexor retinaculum. Here is this palmar cutaneous branch. This is palmar cutaneous branch. This is palmar cutaneous branch. It gives supply to this area. Lateral 2/3 of the hollow of the palm and skin over the thinner eminence. Here is skin over the thinner eminence. Now, this nerve passes after reaching to flexor retinaculum. It passes deep to flexor retinaculum. Here, it passes deep to flexor retinaculum. Here is position of this nerve. This is here. After passing deep to flexor retinaculum, it gives recurrent muscular branch which gives supply to these three muscles or 2.5 muscles. That is, these muscles are abductor pollicis brevis, superficial head of the flexor pollicis brevis, and opponens pollicis. These are the muscular branches. And it also gives branch, palmar digital branch. This is palmar digital branch. There are 4 or 5 palmar digital branch. This palmar digital branch gives supply to anterior surface of lateral 3.5 digit. 1, 2, 3.5 digit. Lateral 3.5 digit on anterior aspect. This is diagram of the dorsal aspect, posterior aspect. Here it gives supply to nail bed of lateral 3.5 digit and also skin on the dorsal aspect over the distal phalanx of lateral 3.5 digit. So this is cutaneous supply, and these cutaneous branches gives, these are motor fibers, gives supply to 2 lumbricals, lumbrical first and second. These are lumbrical first and second. These are supplied by these branches. So this is all about the formation, course and distribution of the median nerve. Thank you. Now discuss about the carpal tunnel syndrome, a very important clinical aspect of this median nerve. Here in this position of flexor retinaculum. This is flexor retinaculum. Here these are 4 muscles related to this thinner eminence. Here 4 muscles are present. The muscles are abductor pollicis brevis. Suppose this is abductor pollicis brevis. Here is flexor pollicis brevis. It has 2 heads, superficial and deep head. Suppose this is superficial head and there is another deep head. Another muscle in this group is opponent's pollicis. Suppose this is opponent's pollicis. Another muscle is adductor pollicis. Adductor pollicis. Suppose this is adductor pollicis. So these are four muscles, group of four muscles which form the thenar eminence. Abductor pollicis brevis, flexor pollicis brevis, superficial head and deep head, opponent's pollicis and adductor pollicis. This muscle, abductor pollicis brevis, is supplied by median nerve. This muscle supplied by median nerve. This muscle, flexor pollicis brevis, this superficial head is supplied by median nerve, and this is deep head, it is supplied by ulnar nerve. This opponent's pollicis supplied by median nerve. This adductor pollicis is supplied by ulnar nerve. So here 2.5 muscle is supplied by median nerve and 1.5 muscle is supplied by ulnar nerve in this group, thenar eminence group. Another muscle is related here, that is lumbricals. First and second lumbricals. This is first and this is second lumbrical muscle. First and second. These are two lumbricals. Here is course of median nerve. This is flexor retinaculum. This is flexor retinaculum. This median nerve passes deep to flexor retinaculum. It passes deep to flexor retinaculum here. Before passing deep to flexor retinaculum, about 5 cm proximal to this, it gives palmar cutaneous branch. This is palmar cutaneous branch. This is palmar cutaneous branch, which gives supply to skin of the thenar eminence and lateral 2/3 of hollow of the palm. If you cut a section at this level, you will find here is trapezium. This is trapezium. This is trapezoid. Here is capitate. And hamate. This is hook of hamate. Here is flexor retinaculum. This is flexor retinaculum. Here is a partition. Here flexor carpi radialis is present. This is flexor carpi radialis. Here is flexor pollicis longus. It's covered by radial bursa. Here is ulnar bursa. It contains tendon of flexor digitorum superficialis here, and here flexor digitorum profundus, potens. Now position of median nerve is here. This is median nerve. Here you can see the position of median nerve. Laterally it lies between these two muscle tendons. That is, here is flexor carpi radialis on lateral side, and medially this is flexor digitorum superficialis tendon for middle finger. So this. Another thing here is this is thinner eminence, and here is hypothinner eminence. This is hypothinner eminence. This is thinner eminence. These four muscles are present in thinner eminence. Here is palmar cutaneous branch, which passes superficial to this flexor retinaculum. This is palmar cutaneous branch of median nerve. This is proper median nerve. So, in case of carpal tunnel syndrome, there is entrapment of median nerve within this carpal tunnel, or there is compression of this median nerve within the carpal tunnel during passing of this tunnel. Cause of compression may be there is tenosynovitis of the ulnar bursa. This is ulnar bursa. There is tenosynovitis of the radial bursa. There is fracture dislocation of these carpal bones. Usually there is fracture dislocation of lunate. In pregnancy or in myxoedema, there may be compression of this median nerve. If median nerve compressed, then what happens? It contains two types of fibers, sensory fiber and motor fiber. What happens if the motor fibers become damaged? The motor fiber damaged, then there is palsy of abductor pulsus brevis, palsy of superficial head of flexor pulsus brevis, and palsy of opponent's pulsus. So patient cannot perform abduction. This is adduction, this is abduction. Patient cannot abduct them. There is loss of opposition and loss of flexion, partially loss of the flexion. So these muscles become paralyzed, and now the unopposed action of adductor pulsus muscle, due to unopposed action of adductor pulsus muscle, this thumb becomes adducted like this and laterally rotated, slightly laterally rotated. This presentation is a typical presentation known as ape thumb deformity or simian's hand. Ape thumb deformity or simian's hand. For the testing of the abductor pulsus brevis, you can use pen test. Hold the pen here and ask patient to touch the pen. If abductor pulsus brevis is paralyzed or median nerve is damaged, the patient cannot touch the pen. So this is pen test. Another thing, there is sensory loss. So ape thumb deformity or simian's hand presenting this condition. Another thing, there is sensory loss over. So here is median nerve which gives supply to these muscles, this muscle, superficial head of this muscle, and this upper pulse. Sensory fibers give supply to, there are 4 or 5 palmar digital branch. The palmar digital branch which gives supply to lateral 3.5 digits. 1, 2, 3, and this is half. Lateral 3.5 digits. It gives supply to thumb, index, middle, and half of the ring finger, an anterior aspect. And also it gives supply to the nail bed and dorsal skin over the distal phalanx of the thumb, index finger, middle finger, and lateral half of the ring finger. So there is sensory loss over these area in case of compression of this median nerve. There is some clinical test. One is tinel sign. Tinel sign. If you percuss here, like this, percussion over the median nerve and the flexor retinaculum, it causes tingling sensation over the area supplied by this sensory nerve, median nerve. This is tinel sign. There is Phylum test, tinel sign, T-I-N-E-L, tinel sign. And there is Phylum test. In this test, in hyperextension of the wrist for 1 minute, patient feel aggravation of the pain and paresthesia due to compression of this median nerve. This test is Phylum test. So this is all about the carpal tunnel syndrome. Now we'll discuss about the clinical importance of the median nerve or Leber's nerve. First of all, here in this diagram, this is carpal tunnel. This tunnel is formed between carpal bones and here is flexor retinaculum. This is carpal tunnel. Here is ulnar bursa, here is radial bursa, here is median nerve. In case of tenosynovitis of these bursa, in case of myxoedema or fracture dislocation of lunate bone or in female during pregnancy, this nerve may compress in carpal tunnel syndrome. If this nerve is compressed here, then what happens? Here, after passing through this carpal tunnel, it gives branch to 2.5 muscle, that is flexor pollicis brevis, superficial head of abductor pollicis brevis, superficial head of flexor pollicis brevis, and opponens pollicis. These muscles become paralyzed. If abductor pollicis paralyzed, then what happens? This is abduction. If abductor pollicis is paralyzed, then you can perform the pen test. A pen, there is pen, use pen and ask to patient touch the pen by their thumb. If abductor pollicis brevis is paralyzed, the patient cannot touch this pen by thumb. Normally, this is abductor pollicis brevis through which this pen can be touched. If this muscle is paralyzed, then patient cannot abduct. So abduction is lost. So this is pen test. By pen test, you can test the abductor pollicis brevis. And other muscles become wasted. So there is a wasting of thinner muscle. One thing. And there is loss of the sensation over the lateral 3.5 digit, which are supplied by this palmar digital branch. There is autonomic zone which can be examined by touching the tip of the index and middle finger. This autonomic zone is area of the skin which is exclusively supplied by that particular nerve. This means this area is supplied by only this median nerve. Here there is overlapping of anterior nerve, ulnar nerve. Here there is overlapping of radial nerve. This tip of these two, if examined, these are exclusively supplied by medial nerve. So this part affected if the median nerve is compressed here. Another thing, if there is a lesion just proximal to this, just proximal to the flexor retinaculum, suppose lesion is here, then what happens? There is superficial, there is this palmar cutaneous branch. This palmar cutaneous branch also cut. Then there is, in addition to all these, there is also loss of sensation over the skin of the thinner eminence and lateral 2/3 of the hollow of the palm. Another thing, if there is lesion at the middle of the forearm, at this level, then what happens? Here, at this position, a branch of the median nerve goes to the radial head of the flexor digitorum superficialis, and this radial head of flexor digitorum superficialis gives tendon to index finger. So tendon for index finger rise from here of the flexor digitorum superficialis. If this part of the muscle is paralyzed, then what happens? Then if you ask patient to clasp the hand, he cannot perform index, he cannot flex the index finger, rest fingers are flexed except index finger. This is pointing index or Osner's clasp hand. Osner's clasp hand or the pointing index. Another thing, if lesion is here, anterior introosseous nerve is damaged, then what happens? Anterior introosseous nerve syndrome of Kilonevin, Kilonevin, anterior introosseous syndrome of Kilonevin. In this syndrome, this anterior introosseous nerve gives supply to 2.5 muscle, that is pronator quadratus, which pronate. This is flexor pollicis longus, which flex at the distal interphalangeal joint, and another thing is flexor pollicis longus, and another thing is lateral half of flexor digitorum profundus. Lateral half of the flexor digitorum profundus. This lateral half of flexor digitorum profundus gives tendon to index finger and middle finger. So these two fingers cannot flex at terminal interphalangeal joint. This thumb cannot flex at the terminal interphalangeal joint, and his pronator quadratus is paralyzed. So patient cannot perform pinch grip. There is loss of pinch grip. If we ask patient to pinch, he cannot perform this action. There is pronation, here is flexion at this joint, flexion at this joint. The loss of pinch grip. So this occurs in anterior introosseous syndrome of Kilonevin. If there is another condition, if there is lesion in cubital fossa, or there may be compression here by Stuthers ligament, there may be supracondylar fracture, or there may be compression anywhere above this cubital fossa. These three muscles also paralyzed. Then what happens? If these three muscles are also paralyzed, then in addition to all these signs and symptoms, other thing you will find, that is bendiction hand. Bendiction hand. What is bendiction hand? Bendiction hand. Here is these 4 digits, 4 fingers. There is 4 flexor digitorum superficialis tendon, flexor digitorum profundus tendon. 2 tendon goes to flexor digitorum superficialis and profundus for index finger, flexor digitorum superficialis and profundus middle, flexor digitorum superficialis and profundus ring finger, and a little finger flexor digitorum superficialis and profundus. 2 flexor digitorum profundus for the index finger and for the middle finger are supplied by medial nerve. Flexor digitorum profundus for ring finger and little finger supplied by ulnar nerve. Here it is presumed that ulnar nerve is intact. Then what happens? If asked to patient to flex the hand, flex the fingers, then here in these 2 fingers, all 2 flexors, flexor digitorum superficialis and profundus, both become paralyzed. So patient cannot flex these 2 fingers. And here flexor digitorum superficialis are paralyzed, which is supplied by medial nerve, and flexor digitorum profundus here is supplied by ulnar nerve. So it partially flexes. The typical position is like this. This is act of blessing by the clergyman. So it is known as benediction hand. This is benediction hand. So this is all about the clinical importance of the median nerve.